Okay, good afternoon, everyone. Thank you for circling back after lunch. I know it's a little bit hard to really engage right after a big meal, but we have a very, very exciting session planned for you, and in particular, a very kind of invigorating talk to wake us up after lunch. It's my great pleasure to introduce Dr. Matt Reveille. He's an associate professor of medicine and our GI section chief at the VA. He'll be talking about the practical approach to chronic constipation and IBS-C. This is really a fitting topic for him, not only because of his decades of clinical experience and published expertise on the topic, but I recently learned actually that this was the topic of the very first internal medicine grand rounds he gave as a chief medicine resident. So if there's anything that comes around full circle, it's constipation. Thank you, Dr. Reveille.
Thank you, Dr. Patel, for that nice introduction. Hopefully I get to be the leadoff hitter today, so the postprandial narcolepsy that you'll experience, I will be ahead of that game because I get the first 20 minutes and food will not have left your stomach. What I'd like to do first, I have no disclosures. I'd like to thank the committee for asking me to participate in this year's conference. It's nice to be face-to-face once again with our audience of participants. But before we actually define constipation and talk about its impact, I'd like to take you through a lesson on colon physiology. And I think after you see this demonstration, you will never again think about how your colon works in any different manner. So I reached into my goodie bag. Now, the colon is unique in its peristaltic function. As it expands each segment, it pushes the waste on to the next segment. And the segments of the colon called the haustral segments work in a teamwork fashion, moving waste, which is liquid at the cecum and becomes solid at the rectum. For the average Western intake, dietary intake, every day you create 2 liters of wastewater that enters from the ileocecal valve into your cecum. By the time that meal reaches your rectum, you have dehydrated that stool to a total volume of 250 mLs. So for a healthy, intact colon, you have roughly an 8-to-1 dehydrating mechanism day to day. So that offers opportunity. If you alter diet, you alter fluid intake, you may actually increase water absorption and therefore have harder stools. And there are other things that may impact the actual transport of that wastewater from the right colon to the left colon. Now, knowing that firsthand also gives us an opportunity for intervention in patients who complain of constipation. I'm going to highlight some general features of constipation, but we really want to focus on the disabling patients who have chronic constipation and irritable bowel syndrome, constipation predominant. So, let me first start off by talking about the toothpaste tube. Your colon is like a toothpaste tube. If it is full of soft, deformable waste, all you have to do to get that first toothbrush full in the morning is pinch at the very back end. And along that force is transmitted from here to the opening to your toothbrush. Now, if you're like me and you like to be thrifty and use toothpaste tubes to the very end, when you've gone through a few weeks of using your toothpaste tube, and now you're at the very last nickel, trying to get this last nickel onto your toothbrush, what do you normally have to do? You have to squeeze hard to get a small volume of toothpaste, which is probably a little dried up because it's been there for 2 weeks, onto your toothbrush. So the point is, if you can keep your colon full of soft, uniform waste, you should not really have problems with constipation. The goals of all the therapies are to create a full, soft, deformable fecal bolus. Now, I'm not saying overfill. If you overfill the colon, that's a different issue. Keep in mind forever the toothpaste analogy. I was blessed to be trained by Sundar Mehta, which many of you know. We have a memorial lecture for him every year, and this is what he told patients who had constipation at every clinic visit, the toothpaste analogy. All right, so let's define constipation. Is it important? You bet. 15% of the world's population has constipation, either acute or chronic. Some estimates in other populations outside the U.S., it's as high as 20%. Now, you would expect people in the Western societies to actually have a higher incidence of constipation. That turns out to be true. There are other areas around the globe where constipation is a more frequent complaint. We're just talking about the general concept of constipation. What's the normal range of bowel movements? Between 3 a day and 3 a week. That defines a 95% confidence interval of surveys amongst all populations for normal bowel habits. What do we get concerned about? We're going to talk about just a simple workup of constipation. Constipation is a frequent reason to seek primary care consultation, and even more importantly, for the more chronic disabling types of constipation, for consulting GI. Is constipation a big deal? You bet. It's a significant impact on quality of life. Patients express frustration with their primary care, with their providers, because they don't think we take them seriously. And maybe we should be listening more to their complaints about constipation. It's uncomfortable. If you've traveled abroad and you haven't had a bowel movement for 4 days and you're used to having a daily bowel habit, you're kind of miserable. Imagine somebody that has to deal with that day in, day out for weeks to months to years, thinking that there's no hope and that they have to live like this the rest of their lives. So we need to throw out a little bit more empathy when we have somebody complaining of constipation. 2/3 of patients with chronic CIC, chronic idiopathic constipation, and IBS-C never ever see a provider. Why? Embarrassment, frustration, those things that I just mentioned to you. And interestingly, Hispanic populations are more likely to seek help for constipation than African Americans, and that supersedes non-Hispanic white populations. All right, let's talk about a little bit of the workup. Initial intake, you all know this, but this is just a highlight. Asking about duration. Is it sudden, acute, or is it chronic? Chronic meaning that it's been lasting more than probably 3 months without abatement. What about the symptoms? Do we ask about the frequency of the stool? Are they straining? Do they have a sense that they have a little bit of an elimination, but they have incomplete evacuation? Do they use manual maneuver to try to extricate stool that just doesn't want to come out? Bloating as a symptom. It's very interesting. In my practice, I've always asked females that are currently of childbearing age that are menstruating, does their bowel habit vary with the menstrual cycle? Progesterone slows bowel motility and increasing the symptom of bloating. Whereas during the estrogen surge early on prior to ovulation, estrogens actually increase visceral sensitivity. And so we need to keep that in mind when we're taking a history. What about stool consistency? Outside there, you've seen the Bristol stool chart. Everyone should have a Bristol stool chart on your cell phone or in your office because it defines what the patient is telling you about constipation. Hard, lumpy stools, tiny little balls. Remember the toothpaste analogy. That's an issue, and we need to identify what is it that they're actually having difficulty passing. And lastly, what about the alarm symptoms? Are they having bleeding with it? Are they having unexplained weight loss? Has there been a gradual progression and reduction in caliber of stool? Very important clinical history. So there you have it. That's the Bristol stool scale. You can take the slides and print it up for your office. There's a ton of these options. You can Google the image, and by the way, and have one for your office. But I think it's a helpful tool, and we encourage our fellows to use that in our GI clinics. Review medications. Boy, I tell you, if you've ever taken a calcium channel blocker or you've been on opiates, you know about their impact on constipation. The mechanism by which these cause constipation is beyond the scope of this talk, and we won't talk about opioid-induced constipation either when we talk about treatment options shortly. But there's a whole list of important drugs that are listed here for your reference that impact and create a constipation environment. During the evaluation, I think you ought to be doing a digital examination. There are lots of clues from a digital examination. They may say they feel like they have retained waste, and you do a digital examination and the rectum is empty. And we ask individuals to squeeze their sphincter, and then we ask them to bear down so we can assess whether their puborectalis is actually moving into the way paradoxically. And that's a different type of constipation, which I will briefly talk about. Diabetes is probably the number one metabolic abnormality associated with constipation. Of all the things that can happen to the diabetic gut, the first and foremost and most prevalent symptom, probably about 40% of all diabetics complain of progressive chronic constipation. Now, if you give them metformin, you might be able to take care of that because, as you know, metformin is very diarrheagenic. So what about just the frontline treatment of constipation? I'll tell you here first, stool softeners, in my opinion, are worthless and they're a waste of money and they probably should not be used at all. There's some suggestion that they may be withdrawn from the market. Bulking agents, psyllium, methylcellulose, wheat dextran, calcium polycarbophil. Those are all the commercial products. You can also get some of those in health food stores. How do they work? Well, they add bulk to the stool. They fill the toothpaste tube and allow the colon to grab hold of a soft waste and move it from one end to the other. You can't take a bulking agent without taking water, however. And you'll see later that water content is critical to normal bowel function. The second group are the osmotic laxatives like polyethylene glycol, PEG 3350. I'm sure everybody in this room has experience with that. There's actually, I tell patients all the time that, look, they did a 5-year study in pediatrics with chronic constipation and proved safety and efficacy over 5 years. So if it's good for kids, it should be good for grown-ups, okay? They all work by increasing luminal water volume. Now, I've highlighted with the double asterisk magnesium-based regimens. You may or may not be aware that just recently, all magnesium citrate in the entire world has been pulled because of bacterial contamination. So magnesium citrate as an option for patients with occasional constipation is probably not an option any longer. But magnesium oxide tablets are, and you can titrate magnesium oxide tablets up to 4 to 6 a day. I'm not going to talk about their role in chronic constipation because that's where we want to be. And then lastly, the direct stimulants, senna and bisacodyl. All right, let's do some definitions here. What we really are talking about is perhaps a spectrum of chronic constipation requiring more advanced medical management, IBS-C versus chronic idiopathic constipation. We'll read the definitions. For IBS-C, recurrent abdominal pain at least 1 day a week in the past 3 months associated with 2 or more of the following symptoms. The pain is relieved by defecation. Very important clue here for IBS-C. Onset was associated with a change in stool frequency. Onset associated with change in form, moving up and down the Bristol scale. Greater than 25% of bowel movements are hard. Less than 25% were loose, and they were not loose because the patient was trying over-the-counter laxatives. And the criteria fulfilled for at least 3 months with symptoms at least 6 months before they're actually diagnosed. Now, on the other hand, chronic idiopathic constipation, symptoms lasting greater than 6 months, with 2 or more of the following symptoms occurring at least 25% of the time. Straining, lumpy or hard stools of Bristol 1 to 2, sensation of incomplete evacuation, sensation of obstruction or blockage at the anal verge, using manual maneuvers to facilitate defecations, less than 3 defecations per week, loose stools not present, and there are not enough criteria for irritable bowel syndrome. Pretty similar discussions, similar definitions. But we'll see that one of the biggest differentiating factors here is actually pain relieved by defecation, and that pain factor for IBS-C really kind of moves it into that category. Most of these 2 categories have normal colonic transit. There is a subset of patients with chronic idiopathic constipation that actually have a slow transit colon. So let's go off to Rome. Everybody likes traveling. We'll travel to Rome. So Rome 4, placed a few years ago, was designed to try to subset some of the functional bowel disorders from the esophagus to the rectum. And as they focused on constipation, we realized one thing. Not all of chronic idiopathic constipation is due to a sluggish, dysfunctional colon. And in fact, 40% of patients who were initially characterized as CIC actually have problems with their defecatory apparatus. They have anal spasm, puborectal spasm, rectoceles, lots of things that cause obstructed defecation either at the rectal level or in the sigmoid. And that group of patients needs to be identified and moved on to specialized testing. The testing includes balloon expulsion testing, high-resolution manometry, and occasionally defecography. But because we're talking about changes in structure during the act of defecation, pharmacology, like I'm about to show you, probably isn't going to be very effective. But what we do know, for patients who have outlet-type problems related to anal sphincter dysfunction, the group of patients I call the dyschesics, just like dysphagia, but it's at the back end, they benefit from biofeedback retraining. And if you correct this distal abnormality in the entire defecation apparatus, you will correct their entire constipation problem more often than not. So that's the goal of trying to identify these folks and get them out of the bucket of CIC so that we can focus on the next categories. So let's talk about some of the new pharmacologic therapies for irritable bowel syndrome, constipation predominant, and functional constipation. So functional constipation, again, those patients with transit abnormalities, infrequent stools, don't satisfy the criteria for IBS-C, and don't have an outlet type problem. We're going to go through these. I apologize for the chemistry I'm about to show you, but it's also fun to show some good science now and then. Let's look at the categories. Pro-secretory agents. They increase chloride fluxes into the colon, which then carries sodium and increases water volume to the stool to soften. And as you volume expand the stool, you increase the peristaltic reflex. Sounds like a good idea. Chloride channel activators, guanocyclase C agonists. The next group is the 5-HT4 direct agonists, or the prokinetics, the classic prokinetics that actually have direct action on propulsive motion of the smooth muscle of the colon. A new group called the sodium hydrogen exchanger type 3 inhibitors. And lastly, a bile salt reuptake inhibitor. Now, 90% of the bile per meal is reabsorbed in the terminal ileum, and 10% reaches the colon. You all have cared for patients who've had cholecystectomy who have bile salt diarrhea. That's because their bile salt production has to increase by a factor of 3 by the liver to accommodate the fact that they no longer have a gallbladder for storage between meals. Ergo, there's 3 times as much bile that passes through the terminal ileum and enters the colon. Well, it turns out that bile in the colon in excess actually activates chloride channels and makes your colon a secreting organ as opposed to an absorptive organ. So bile salt reuptake inhibitors may have some role here. So the pro-secretory agents, lubiprostone was the first out there. Lubiprostone is an analog of prostaglandin E. It activates the chloride channel, increases stool volume and moisture. 2 others that actually are guanocyclase activators. They increase intracellular cyclic GMP and are able to increase chloride fluxes back into the lumen. And lastly, the bottom one, B here, is actually called ilabexapat. That is an inhibitor of bile acid transporter. Therefore, it increases bile salts to the colon, again, increasing secretion. Now, the true prokinetics are my favorite because I'm a motility person. The classic was cisapride that was removed from the market. Most recently, tegaserod was again removed from the market by the FDA due to cardiac concerns, so we no longer have that as an option. But the one we do have is procalcipride, first-in-class drug that activates 5-HT4 receptors on the smooth muscle and accelerates propulsive activity and forward propulsion of the colon. And this is the latest and greatest thing that I've seen, but I tell you, I don't think even I can afford it. This is called tenapanor. This particular chemical inhibits the sodium hydrogen exchanger 3, and we'll show you graphically in a minute how it increases salt and water volume in the colon. On the right side is a schematic of the colonic mucosa. It shows each of these pumps as they sit on the surface of enterocytes. The sodium hydrogen exchanger is on top, guanocyclase is in the middle, and chloride channels at the bottom of the first cell. So tenapanor inhibits sodium hydrogen and increases sodium flux. It also increases luminal phosphate, but doesn't have any major impact on serum phosphate. Linaclotide activates the guanocyclase, as does plecanatide, which is the new one in that class on the market. And lastly, lubiprostone at the bottom, activating the chloride channel. Pay attention. The net result of everything I've just told you is increased chloride and sodium and water passively into the colon to soften the stool, bring moisture, expand volume, enhance peristaltic activity. So the drugs that are approved for IBS-C include the following. To the right is actually the average wholesale price in the recent version of the medical letter. They're not cheap. Pega's a lot cheaper, I think you'd admit, than this particular set of agents. And as you noticed at the bottom there, tenapanor currently on the market is $1,500 a month. Seems like an awful price to pay to try to alleviate the constipation. On the other hand, for chronic idiopathic constipation, our functional group, we have lubiprostone, linaclotide, plecanatide, and procalcipride. Whether these other new agents I propose to you will be approved for CIC remains to be determined. But if you look at both the CIC and the IBS-C agents, they accomplish the same thing, and I see no reason not to anticipate that they actually will be approved for both indications with time and good research. Cost considerations, really a big one. At the VA, we have a formulary that's cost-based but also efficacy-based, so we can triage patients with different forms of constipation and select the appropriate agent. I will tell you, even for commercial insurance, most of the time you get this pushback that you have to try all the usual stuff first. That's not what we're talking about. We're talking about the patients for which OTCs don't work. And 93% of patients with constipation use 1 to 3 OTCs, and they never tell their doctor about it. And currently in this country, only 1% of patients with chronic constipation are actually using pharmacologic agents like these by themselves. You have to think about side effects. You can't use lubiprostone in pregnancy. It's a prostaglandin E analog. It's a no-no. And side effects. Almost all of these, as you might imagine, give you diarrhea if you take them too much. They cause nausea, and that nausea is a big problem, and with at least one of these agents, headache and joint pain have been described in patients that I've cared for. So selection considerations, I'm not here to tell you what's the best selection for your patient, but you just have to keep this into the mix as you think about how you're going to treat constipation. These are some of my references. I want to share with you one final quip. There are probably only a few in this room that will remember these days, but back in the 60s, there were radio commercials that were sponsored by vitamin companies and laxative companies. And at the conclusion of the hour long, there was a 30-second commercial. And this one was particularly germane to X-Lax. And at the very end, the announcer said, "Thanks for loosening."
Thank you so much, Dr. Reveley. An outstanding review of a very, very challenging clinical topic. I'd like to invite our next speaker to approach the podium, Dr. Wasim Ahmed, who is an assistant professor at the University of Colorado and a member of our Crohn's and Colitis Foundation, who's going to be talking about a really interesting clinical scenario and question about when we can de-escalate medical therapy in inflammatory bowel disease. Thanks, Dr. Ahmed.
All right, well, good afternoon, everyone. Thank you for the organizers for giving me the opportunity to speak to you today. I'll be talking today about the de-escalation of medical therapy in inflammatory bowel disease, when and in whom to consider. I have no relevant financial disclosures. Our learning objectives for today's talk are to discuss why to consider de-escalation of medical therapy and in whom, to summarize the current data on de-escalation of combination therapy, and finally to review how to monitor patients undergoing de-escalation of medical therapy. So just some basic definitions. What is de-escalation? De-escalation is the removal of a medical therapy from a combination treatment regimen or the decrease in the frequency and or dosage of a monotherapy, whereas withdrawal is the discontinuation of all medical therapy altogether. So why would we even de-escalate medical therapy in our patients? Well, first of all, we have to think about side effects, right? Some of our drugs do have serious side effects, and we want to minimize those if possible. In particular, with our patients with IBD, we think about concerns of infection and malignancy, mainly looking at lymphoproliferative disorders and skin cancer. In particular, we think about side effects in patients at higher risk for them. So this includes the younger population, the elderly, and travelers to endemic areas where we have specific infectious concerns. We also have to think about using therapies that could potentially exacerbate our patients' comorbidities. So, for example, should we be using a TNF antagonist in a patient with decompensated heart failure? And then finally, we have to take into consideration costs of care, not only to our patients, but also to our healthcare system as well. And also think about access. Unfortunately, we do realistically live in a world where payers often have preferences that we have to keep in mind when we think about treatment options. And finally, what are the preferences for our patients? What do they want to be on? And if they are interested in de-escalation, why? So why should we not de-escalate therapy in our patients? Well, obviously they could flare. If our patients lose control of their disease, they're at increased risk for complications such as surgery, being hospitalized, or being exposed to systemic steroids. And finally, if we do restart that therapy, what if it doesn't work again? We might not be able to recapture a response with their prior therapy, and that is of concern because we still live in an era with limited treatment options. And furthermore, when we do start certain therapies, such as TNF antagonists, we always have this fear, is their patient going to be at risk for forming antibodies to their drug? So before we go into de-escalation, we have to talk about what are the purpose of the therapies we use in IBD? What are the actual goals of our treatment? Well, if you look at the most recent STRIDE 2 guidelines, which kind of define treatment targets in IBD, we have not only short-term targets, but also intermediate and long-term targets as well. Short-term targets are primarily based upon symptomatic response of patients in achieving, essentially clinical remission, whereas the intermediate targets go more so into not only sustained clinical remission, but also decreasing our biomarkers and achieving what we call biochemical remission as well. Well, what are our long-term targets? That's primarily looked at as achieving what we call mucosal healing, which is currently defined as endoscopic healing, with the ultimate long-term goal of normalizing our patient's quality of life and avoiding any sort of long-term disability. So how do we go about doing this? We don't just put our patients on treatment and cross our fingers that they're going to do well. We actually use what's called a treat-to-target approach for patient care when we start a patient on treatment. So we identify what their risks are at the beginning, what treatment is most appropriate for them, and then we start them on a therapy. We don't just, let them go off into the world and see how they do. We have to use predefined assessments at specific time intervals, which are usually, 6 months, or 3 months or 6 weeks, depending on what data you look at. And we assess how they're doing. Are they reaching the targets that we've defined, those short-term, intermediate, and long-term targets? And if they are not, we have to assess them to figure out why. Do they have some kind of intercurrent infection? Is the drug underdosed? Is the drug just not working? And if that's the case, do they need to be on something else? Only then, if our patients reach their ultimate goal treatment target and have achieved sustained mucosal healing with clinical remission, free from steroids, should we actually consider this idea of de-escalation. So let's go over a case. We have a 25-year-old male with a past medical history of stricturing ileocolonic Crohn's with perianal fistulizing disease who's currently on combination therapy with infliximab and azathioprine. He was diagnosed at the age of 23 after presenting with a perianal abscess, and at that time he underwent a colonoscopy showing severe Crohn's disease with a visible perianal fistula and abscess. He was then referred for an exam under anesthesia, underwent incision and drainage of the abscess, and then underwent placement of a perianal ceton and was started on the above regimen. Currently, he sees you in clinic, he feels well, the ceton was removed, and he just had a colonoscopy, which is consistent with endoscopic remission, and you, being the provider, also just happened to check an infliximab drug level that was 12. And so he sees you in clinic and he brings up the following question. I'm concerned about my risk of lymphoma. Is it okay if I stop my azathioprine? So what do we do for this patient? What's the most appropriate change to the patient's treatment regimen? Is it A, stop azathioprine and continue infliximab as a monotherapy? B, no change, he's doing well, keep him on his combination therapy. C, changes azathioprine to methotrexate. D, stop infliximab and continue azathioprine monotherapy alone. Or E, stop all of his therapies together. So this is what we're going to dive into. Before we do that, though, why do we even use combination therapy in patients? What's the purpose of this? Well, we actually do have high-quality randomized controlled trial data, both in ulcerative colitis and Crohn's, which I'll go over, which suggests that combination therapy may be superior than monotherapy alone. And so if that's the case in patients with severe disease, patients with perianal disease, ileal disease, young patients, patients who've undergone surgery, it might be beneficial to use a combination approach rather than a monotherapy strategy. We also sometimes will use combination therapy to prevent the formation of anti-drug antagonists, in particular to TNF inhibitors, and furthermore to increase the level of TNF antagonists as well. So this is the SONIC trial, which I'm sure many of you have heard of. This was a randomized controlled trial in biologic-naive patients with moderate to severe Crohn's disease who were randomized to 3 different treatment arms, either combination therapy with infliximab or azathioprine, monotherapy with infliximab with placebo versions of azathioprine, or monotherapy with azathioprine with placebo versions of infliximab. As you can see, patients on combination did significantly better in terms of rates of steroid-free clinical remission compared to patients on either form of monotherapy. Now, part of the controversy with the SONIC trial is the question of why this is. Why do our patients benefit from combination therapy? Is it potentially the additive treatment effect of the azathioprine alone, or is the azathioprine itself just augmenting the drug level of infliximab, which does seem to be the case when you look at the data. Regardless, why are we concerned about combination therapy? Well, we do have legitimate safety concerns with the long-term use of some of our medicines, in particular thiopurines. And we have large population-based cohort studies which have shown an increased association with long-term use of thiopurines, in particular with rates of serious infections and primarily lymphomas as well. And furthermore, this risk is even higher with the use of with combination therapy with a TNF antagonist and a thiopurine. In regards to thiopurines, in specifics of risks of infection and lymphoma, it seems like the safety concern is primarily with long-term use. So typically the rate of a lymphoma is slightly increased with a patient on thiopurine after about 2 years of exposure. And this is particularly so in higher risk groups or primarily the elder population. Interestingly, if you remove the thiopurine exposure from a patient on combination therapy, that risk actually seems to return to baseline, almost similar to a patient who's never been exposed to the drug. So if our patients are doing well on combination therapy and have achieved mucosal healing, maybe it would be beneficial to remove this from their treatment plan. So what data do we have for this idea of de-escalation? What's the story so far? So the STORY trial was a study that was published about 10 years ago, which was until recently kind of the landmark paper for this idea of de-escalation. This was a prospective observational study primarily based in Central Europe, where about 115 patients with moderate to severe Crohn's disease electively underwent infliximab withdrawal. Now, these were patients who were already on combination therapy with infliximab and a thiopurine and decided themselves to undergo withdrawal of infliximab. And so what happened in that patient population? Well, unfortunately, despite even continuing their thiopurine at about a year of infliximab withdrawal, about 40% of patients had a relapse. At about 2 years, that number increased to 50%. And just recently, there was another paper describing the longer-term outcomes of this cohort, which showed that up to 7 years after withdrawal of infliximab, unfortunately, only 20% of patients were still in kind of a biologic-free clinical remission. So as you can imagine, this was the best data we had up until recently. While it is prospective, it is observational. There's no control group, and there are significant limitations to which to draw conclusions from. So what do we have now? So now we actually have the SPARE trial. This was actually a follow-up from the same group who published the STORY trial, analyzing the withdrawal of infliximab or thiopurine in patients with Crohn's disease in sustained remission on combination therapy. Again, these were patients with Crohn's disease on combination therapy for over 1 year who are already in sustained steroid-free clinical remission for greater than 6 months. And these patients were randomized to either stopping infliximab, continuing combination therapy, or stopping their thiopurine. So this is the study design of the SPARE trial. As I mentioned to you, there are 3 treatment groups. Again, continuing combination therapy, discontinuing infliximab, or discontinuing the thiopurine. And there were kind of predefined plans in place should the patients relapse in each of these groups, which involved either optimizing infliximab, restarting infliximab, or restarting the thiopurine. So what did the authors find? Well, if you look at the relapse rate of over 2 years, in the cohort who stopped infliximab, approximately 40% of them had a clinical relapse. Interestingly, if you look at the other 2 cohorts, the group in which continued combination therapy or the cohort which stopped their thiopurine, these groups had very low and similar rates of relapse, and notably that includes the patients who stopped their thiopurine, which suggests that might be a feasible option for patients. Now, one of the other interesting findings from this study was, that the mean actual time spent in remission in this patient populations were about the same for the 3 treatment groups. So what does this mean? That means that if you actually stop the drug, the patients failed, they relapsed, and you restarted their therapy, almost all patients were able to recapture a response upon resumption of infliximab. Now, this is a very important paper for us in considering shared decision making with our patients, but there are limitations to it as well. So, namely, there's no placebo group. And furthermore, this was an unblinded study, so patients already knew if they were withdrawing a therapy or if they were continuing a therapy as well. Furthermore, if you looked at my inclusion criteria for the SPARE trial, these were patients in sustained clinical remission for over 6 months. Now that sounds great, but I just talked to you about what are our treatment targets for these patients, and that's mucosal healing. So we don't actually know if that was achieved in this group. So to follow that up, we have the Stop It trial, which was a multi-center, randomized, double-blind, placebo-controlled withdrawal study of infliximab. This was just published in the New England Journal of Evidence just a couple months ago. It was a Scandinavian study looking at patients with moderate to severe Crohn's disease in not only clinical, but also biochemical and endoscopic remission as well. Patients were on infliximab for over 1 year, and approximately 50% of them were already on combination therapy, and upon withdrawal of infliximab, stayed on their thiopurine. So what were the findings from this trial? Well, in the patients who stopped infliximab at 1 year, 50% of them relapsed, whereas the patients who continued their infliximab, none of them did whatsoever. So that's a pretty significant findings. Now, small numbers, there are about 60 patients in each cohort, but still, this is the best level of evidence that we have. What if you stratify the infliximab withdrawal patients based off of those who continued their thiopurine or those who were not on their thiopurine? Still, you see there were very similar rates of relapse within a year. Granted, the patients who continued on a thiopurine did have a delayed time to relapse compared to patients not on a thiopurine. So based off of this data, how do we individualize a decision for de-escalating medical therapy in our patients? Well, if you actually look at sub-analyses of all of these studies, all the observational data, we have identified certain risk factors that portend a patient to either have being in the low-risk category or high-risk category for relapsing after de-escalation. Some of the parameters we look at are patient demographics, disease features, their treatment history, their current disease status, and their preferences themselves, and furthermore, are they in clinical remission? So in what scenarios would you think about continuing a patient's medication? Well, these would be in patients with more severe disease, typically those who are diagnosed at a more younger age, patients with, perianal disease, ileal disease, extensive disease, patients who have undergone previous surgery for IBD, have failed medical therapies, have had recurrent use of steroids, patients who have active disease at this time of thinking about withdrawal, and patients who do not have comorbidities that we are concerned about. So despite that, though, as I mentioned to you, still maybe 7-8 years after stopping a drug, maybe 20-30% of patients actually do okay and remain in clinical remission. And so as you can imagine, some patients actually might want to take that chance. So if we have that conversation, particularly with high-risk patients, what do I do? What's my approach with them? I think it's really important to inform them as best as possible. And so, some of the particular things I'll talk about are the actual risks of the drug themselves, which they are often very scared about. I have plenty of patients who tell me that they really believe that infliximab is going to cause cancer in them, or they're at serious risk of infection with infliximab. And while we do have, validated prospective data in large population databases which have shown an association with infections in patients on infliximab relative to patients not on infliximab, interestingly, when you actually look at the biggest risk factors for infections for patients, it's patients on prednisone, patients on narcotics, and actually patients with uncontrolled severe Crohn's disease. So when I kind of put together my IBD safety pyramid of medications for patients to go over and have a shared decision-making session with me, I think it's most important to really harp on the fact that the largest form of harm to them is to have uncontrolled disease. And in my mind, that actually portends them the highest risk of morbidity in terms of infections, hospitalizations, and surgeries. So putting this all together, how do we actually go about de-escalating a patient? We have to discuss the risks and benefits of this approach with them. We have to actually confirm that they're in deep remission with mucosal healing for greater than 1 year on their current regimen. We have to confirm that their current medical therapy regimen is optimized, and we often will use therapeutic drug monitoring to do so. If at that point we have achieved those 3 factors, we will consider de-escalating whatever therapy they prefer. At that point, we don't forget about them. We have to monitor them for relapse with serial clinical and objective assessments, and we have to have a rescue plan already predefined that can be implemented very quickly should they relapse. How do I do this? This is a slide I borrowed from the Monday Night IBD Twitter algorithm, which I used to be largely involved with. I essentially practice this way as well. But again, I make sure my patients are in remission. That doesn't just mean symptoms, that means they've achieved mucosal healing. If they haven't, they're not a candidate for de-escalation and their therapy needs to be optimized. Whether their medicines need to be increased in frequency or dosage, or they just need to be on a different regimen altogether. If they are in true remission, then we actually have a conversation. We engage in shared decision making, go over the risks and benefits of either approach. And then I also perform therapeutic drug monitoring of not only both their TNF antagonists, but also their thiopurine as well. In patients who I believe have an adequate TNF level, I think it's reasonable to withdraw the thiopurine. So, in conclusion, complete therapy discontinuation should generally be discouraged. Combination therapy de-escalation is reasonable and should be considered when appropriate. Clinical remission is an insufficient argument to stop therapy. We have to instead aim for a durable, steroid-free clinical, biochemical, and endoscopic remission before we have that discussion. It's important to monitor disease activity after de-escalation and to adjust therapy accordingly. And finally, everything I talked to you about is with infliximab and thiopurines. We have no data on the idea of de-escalation for patients on novel biologics or small molecules. So going back to our case, what's the most appropriate change to this patient's treatment regimen? I hope after the information I kind of talked to you about today, I think the first three options are all reasonable for this patient. So I think you could stop his azathioprine and continue him on infliximab alone. He's achieved a durable remission. There are potential risks of long-term use of azathioprine, particularly in very young patients when we think about the risks of hepatosplenic T-cell lymphoma. We could do nothing. He has high-risk disease, he has perianal disease, he's achieved clinical remission, he's very functional. Maybe we just continue him on what he's on. Option C is also probably reasonable from my standpoint. We could change his azathioprine to methotrexate. Methotrexate is another immunomodulator with perhaps a better safety profile compared to thiopurine with a decreased association with lymphoma. However, now looking at the last two options, stopping infliximab and continuing azathioprine alone, or stopping both infliximab and azathioprine, I hope you can appreciate after this discussion that this patient would probably have a high rate of relapse. So that's all I got. Thank you again. I do not have a toothpaste object, but my analogy for the treatment of IBD is it's like wearing sunscreen. If you put it on, you can go outside, you're going to thrive, enjoy life, and be functional. If you don't put it on, you're going to get burned. Okay.
Thank you so much, Dr. Ahmed. That was outstanding. A lot of recent data that I think will very much change how we approach de-escalation in our IBD patients. Really appreciate that. So I'd like to welcome our next speaker to the podium, Dr. Debbie Chen, Assistant Professor of Medicine at the University of Colorado. We have a shout out from Polly, noted. And this is a topic that I think will be relevant to literally everyone in this room. Our endoscopy nurses who, the moment we start an upper endoscopy, we shout out gastric biopsies, CBX, Antrim body, rule out H. pylori. Dr. Chen's going to talk to us about why we do this, why it's important, and how to actually clear these infections when we finally find them. Thank you very much, Dr. Chen.
Hi everyone, so my name's Debbie Chen, so I'm one of the faculty as Swati mentioned, and it's thank you so much for the opportunity for speaking to you guys today. I have no financial disclosures. So in terms of the outline of my talk today, I'm going to go over the background of H. pylori, then I'm going to go into testing, including when and how. Then I'm going to chat about initial treatment options for H. pylori, along with the importance of eradication and treatment of refractory infections. And then that's going to lead me into talking about some of the new treatment options for H. pylori. So as we know, H. pylori is a chronic, prevalent bacterial infection. Urease is a very important feature in it, including for its importance with how it survives in the gastric lining in itself. And then it's also important for testing, which I'll get into. In terms of the mechanism of transmission, this is unclear. What we do know, it seems that H. pylori is acquired during childhood, and some of the risk factors we know that's associated with it includes people who have more siblings, and they also have an infected parent, specifically more so in the mother, and then low socioeconomic status. So this leads me into talking about the epidemiology. Now, this was a systematic review and meta-analysis that was published in Gastro that looked essentially at the global prevalence of H. pylori. Now, what we do know is that H. pylori varies across the globe. The U.S. has a prevalence about 35%, with a wide range within the U.S. in itself. For instance, you can see here, Alaska has the highest prevalence at a rate of greater than 70%, with the lowest rate being in our non-Hispanic white population. One factor that's important to consider, especially for us here in the U.S., is thinking about our immigrant population, as their prevalence risk is going to be more reflective of their native country. Additionally, as you can see here, across the globe, it's going to vary from country to country. Africa has a high rate at about 70%, with high rates occurring in parts of Asia as well, including Western countries such as China, Japan, and Korea. So this leads me into talking about H. pylori complications and also when to test. So as we know, H. pylori leads to peptic ulcer disease. This is what led to the Nobel Prize back in 2005. So it's important, based on our ACG guideline from 2017, that in people who have active or prior history of peptic ulcer disease without any prior treatment for H. pylori, that they get tested and treated. Additionally, we know that we have malignant complications of H. pylori. It's a low rate at about 1 to 3%. However, what we do know is that about 89% of all gastric cancers globally can be attributed to H. pylori, which is what led the WHO to designate it as a carcinogen. So this leads me into talking about gastric malt lymphoma, which we know responds very well when treated and people are positive for H. pylori. However, the response to treatment can be variable. For instance, people can have delayed or recurrence of H. pylori. And then also, this leads me into talking about testing and treatment, where we know that low-grade gastric malt lymphoma, they do benefit from eradication of H. pylori if positive. However, it also seems that people who have high grade will also respond as well. In terms of gastric adenocarcinoma, we know that this is important globally, as certain countries have higher rates of gastric cancer, including in areas where there's higher prevalences of H. pylori. There are, for instance, the Asia Pacific consensus guidelines do dictate now to have population-based screening, given the benefit of testing their overall population and the benefit in terms of preventing gastric cancer. In terms of our ACG guidelines, what we do know is after endoscopic resection of early gastric cancer, people do benefit from testing and treatment for eradication of H. pylori, as this can help prevent metachronous cancer. So in terms of considerations for testing, basically areas that's less clear-cut, this is, again, part of the ACG guidelines from 2017, but just to walk through it, dyspepsia, specifically in patients who are less than 60 without alarm features, is one area to consider. Another area are people prior to chronic NSAID use, as studies have shown that people who are tested and eradicated before have a reduced risk of peptic-related ulcer bleeding. However, in terms of people who are already on chronic NSAIDs, this is a little less clear whether or not they benefit. This also applies to people who are on low-dose baby aspirin. In terms of iron deficiency anemia, there have been studies that show that people who have H. pylori and are eradicated for it with oral iron have a better response in terms of iron levels, as well as hemoglobin response, compared to those who are just treated with oral iron alone. And this felt to be in the setting of decrease of iron absorption in people who have H. pylori. Finally, the last area to think about testing and treating is ITP patients. As we know, there is a secondary ITP associated with H. pylori, and there have been studies that showed where people who have less severe disease, meaning platelet counts greater than 30, as well as areas of higher prevalence of H. pylori, do gain benefit in terms of testing and eradication. So as we know, there's multiple different options for testing for H. pylori, including urea breath test, as well as a fecal antigen test, and then upper endoscopy with gastric biopsies, including with biopsy urease tests, and then immunostains with such as GAMSA. So all three of these tests do have high, greater than 90% sensitivity and specificity, and all considered equally good tests in terms of testing, as well as checking for eradication. Some of the factors we know that can impact sensitivity includes recent PPI use within the last 1 to 2 weeks for all of these, as well as recent antibiotic or bismuth use, which is important as those are our treatments for this infection within the last 4 weeks. In terms of active GI bleed, this does affect the sensitivity in people who have biopsies, specifically with the urease test. So in patients who have peptic ulcer bleeds and are admitted in the hospital, it's a consideration to actually get the fecal antigen test, since bleeding does not impact the sensitivity of that test. I just want to quickly touch on the serology test or antibody for H. pylori. I do not typically incorporate this as part of my practice, given the limitations with it, including a high false positive rate in low prevalence areas, and also the fact that it doesn't distinguish between, for instance, prior infection versus active infection. However, one thing I did want to mention is the guideline does say that in cases where there's a high pretest probability, for instance, peptic ulcer disease, you could consider this test as a test to check for H. pylori. So this leads me into talking about treatments for H. pylori. As we know, one of our old prior commonly used regimens was a clarithromycin-based therapy. I'm also going to talk about the more commonly used now bismuth quadruple therapy, as well as a levofloxacin-based therapy. In terms of our other therapies here, they were more studied in other parts of the world, for instance, say parts of Asia. So that leads me into talking about factors to consider, where basically all of these treatment options, there are limited studies where, for instance, a lot of studies may be conducted in specific countries or part of the world that may not necessarily be applicable to everywhere, for instance, here in the US. Additionally, there are limited studies that directly compare these treatment options, making it difficult to compare. One thing, however, does seem clear is that longer treatment durations seem to have higher eradication rates, meaning people who have treatments for 14 days do better than 7 or 10 days. So in terms of picking your initial treatment option, this is a nice flow diagram that was in the ACG guideline, essentially taking into account first whether or not someone has a penicillin allergy, and then their prior antibiotic exposure, such as macrolide, due to concerns with antibiotic resistance, which is a rising concern in terms of our treatment options with H. pylori. In terms of resistance rates, you can see on the table on the bottom left here, you can see that there are high resistance rates with metronidazole, levofloxacin, and clarithromycin, which are all of our commonly used medications for H. pylori. However, there are low resistance rates with amoxicillin, tetracycline, and rifabutin. One thing to emphasize, though, in terms of the resistance rate with metronidazole, it appears that this rate does improve with higher doses as well as concomitant use of bismuth. In terms of the flow diagram to the right, one thing I did want to highlight is regardless of the type of penicillin allergy or macrolide exposure, basically whichever group they fall under, bismuth quadruple therapy is always an option, which is why it has also risen in terms of first-line therapies and more commonly used. So this leads me into talking about eradication of H. pylori. So this is important because, like I said, there is unfortunately a declining success of eradication with H. pylori, and as we know, we want to prevent some of the complications. So there's many feature or considerations or factors that go into why someone may fail eradication. Basically, as I mentioned, antibiotic resistance is certainly consideration, but other features now to consider too includes things like their genetics, so things like CYP2C19, along with overall non-adherence, just given the complexity of these drug regimens, including as well as side effects of the drugs. Other things to think about include acid suppression. What we do now know is the goal pH in the stomach is about 6 to 8, as more acidic conditions can lead to decreased half-lives of antibiotics, including amoxicillin and clarithromycin. Finally, another factor to think about in your patient is going to be people who smoke, as we know this can also reduce eradication rates. So in terms of treatment for refractory infections, this is a flow diagram that was published in the Clinical Practice Update from Gastro last year. In terms of features to think about, it's going to be, for instance, whether or not your patient truly has a penicillin allergy. What we do know is people who report a penicillin allergy, actually greater than 90% actually have a negative skin test. So certainly something to think about in terms of referring to allergy for true testing to give yourself more options. Other things to think about, like I mentioned, is going to be antibiotic resistance as well as prior exposure to help limit see what they may potentially fail. In the case of people who have, say, more than one refractory infection, thinking about obtaining culture and sensitivity data. However, H. pylori is notoriously difficult to culture, so it's certainly something to think about, although maybe more complicated than you think. So this leads me into talking about new treatment options for H. pylori. The first is going to be high-dose dual therapy with esomeprazole and amoxicillin. The next is going to be omeprazole, rifabutin, amoxicillin, which was approved by the FDA in 2019. And then I'm going to talk briefly about the potassium competitive acid blocker, vonoprazan, and the base therapies with clarithromycin and amoxicillin. So in terms of high-dose dual therapy, this is one of the therapy options that essentially optimizes antibiotic dosing as well as PPI use, basically increasing the dose frequency to help overcome the issues with short half-lives, and then also increase acid suppression. There was a multi-center randomized control trial that was done in China that showed that essentially this regimen was non-inferior to clarithromycin, amoxicillin, PPI, and bismuth. There also has been a systematic review and meta-analysis that showed that essentially this regimen was similar in terms of efficacy with our commonly used first-line therapies. In terms of rifabutin-based triple therapy, so the brand name is called Talicia. This was approved back in November of 2019. Essentially incorporates 4 capsules that, with each capsule including each of these 3 medications, and is taken every 8 hours. So in terms of the phase 3 US-based double-blind trial, it does appear that the eradication rate is significantly higher with a rifabutin-based therapy compared to high-dose PPI and amoxicillin. In terms of side effects, it seems that diarrhea may be slightly higher with a rifabutin-based therapy. Otherwise, other adverse events were pretty similar. One thing to mention in terms of that clinical practice update from Gastro last year, they mentioned thinking about rifabutin-based therapy for more than 2 failed prior treatments. So finally, I'm going to talk about vonoprazan-based therapy, or Voquenza, which incorporates amoxicillin plus minus clarithromycin and was just approved this past May, and essentially is our new potassium competitive acid blocker. One thing that's important is that it bypasses the CYP2C19 metabolism, which is important in certain ethnic groups, which may not handle PPIs as well in terms of acid suppression. In terms of their phase 3 trial, it looks like that they compared both of these different regimens with lansoprazole-based triple-based therapy with clarithromycin and amoxicillin, and found that these were non-inferior to the lansoprazole control group. However, in clarithromycin-resistant infections, it does appear that both were superior significantly. They had similar adverse events across all 3 groups. So in summary, H. pylori is a chronic infection with significant global impact with variable prevalence across the world. It's important to test and treat in specific cases of peptic ulcer disease, people with gastric lymphoma, as well as early gastric cancer. In terms of areas to think about testing, it's going to be our patients with dyspepsia, iron deficiency anemia, prior to chronic NSAID exposure, and then ITP. In terms of eradication, it's important to test giving declining success with treatments. What we do know is antibiotic resistance is shifting the efficacy of our previously used treatments, for instance, such as our clarithromycin-based therapy. Factors to consider now when optimizing treatment for your patients going to be essentially optimizing acid suppression with consideration of potassium competitive acid blockers or more frequent or increased dosing of PPIs, along with antibiotic resistance and pharmacokinetics with more frequent and higher dosing, and then also thinking about duration of treatment, as I mentioned, with increasing the length to 14 days if possible for your patients.
Thank you so much, Dr. Chen. All right, to round out this session, I'll invite my colleague and friend, Dr. Kelly DeLay, to the podium. She's an assistant professor of medicine. Another shout out. Thank you, Polly. You're going to have to keep that up now for the rest of the day. Assistant professor at the University of Colorado and also at the RMRVA. And she's going to be talking about small intestine bacterial overgrowth. Thanks, Kelly.
Hey, good afternoon, everyone. Thank you to the course directors, Amanda and Swathi, for inviting me to speak today. So, small intestine bacterial overgrowth, you've been waiting all day for it. Here we go. All right, I have no financial disclosures. So our agenda today is to discuss the current definitions of small intestinal bacterial overgrowth, I'll refer to it as SIBO, identify which patients are at risk and which diagnostic options we have, what treatment options are out there, and how to address recurrence of SIBO, which doesn't occur uncommonly. So SIBO was defined over 50 years ago, actually. At this time, it was a focus on malabsorption and maldigestion, so patients were presenting with this classical presentation of weight loss and protein-losing enteropathy, pretty severe presentations. This was generally in patients who had GI surgeries, blind loop syndrome, and so over time, the definition has changed. Now, it's well accepted that excessive numbers of bacteria in the small bowel causes GI symptoms is kind of our current definition. This is based on a jejunal aspirate, so we're pulling fluid out of the jejunum, and positively considered bacterial counts that are greater than 10 to the 5th CFU per ml, and that's colony forming units per ml. So that was historically how that definition changed. But there was a big systematic review in 2008, a landmark meta-analysis that evaluated the validity of the diagnostic tests for bacterial overgrowth. They included 71 studies, and they discovered that this cutoff of 10 to the 5th CFU per ml was not adequately validated, nor was any other cutoff value. In fact, with all of these 71 studies that they looked at, there was a wide variability in the diagnoses that were included, where it was sampled, jejunum versus duodenum, how it was sampled, the volume that was sampled, and how it was cultured. So essentially the bottom line was there's no universally accepted or validated gold standard for diagnosis. What they did find, however, was that in asymptomatic healthy controls, small intestinal bacterial counts rarely exceeded this 10 to the 3rd CFUs per ml. So the 10 to the 5th cutoff previously accepted generally referred to patients who had had intestinal surgeries or who had altered anatomy. So this became the new definition moving forward. When do we look for SIBO? So there's the classical presentation that I mentioned before, patients who typically have altered structural anatomy. There's clinical presentations, bloating being a very predominant symptom, abdominal pain, flatulence, diarrhea, and actually constipation, which we'll talk about in a little bit. And then patients with risk factors, so underlying conditions. And in the AGA clinical update in gastro published in 2020, they presented this table as possible risk factors for SIBO. So moving from left to right, abnormal small intestinal motility, you want to think about anything that causes intestinal stasis, essentially. So these are patients with diabetes, patients with scleroderma, amyloidosis, gastroparesis, and definitely think about it in your patients who are chronic opiate users. Anatomic abnormalities mentioned before, potentially Crohn's disease, immune deficiency, patients on PPI therapy, again, not uncommon, patients are on acid suppressors. And then this catch-all multifactorial column, so not insignificant associations here in this column. So we mentioned acid-suppressing drugs as being significant, but remember always about SIBO in our patients with cirrhosis. So SIBO has been associated with hepatic encephalopathy, as we know, as well as SBP. In celiac disease, significantly associated, and in Crohn's disease. So typically the phenotypes of fibrostenotic disease, anything causing that intestinal stasis, or in patients who have had surgery, potentially an ileocystectomy. So our diagnostic options are the duodenal jejunal aspirate, as I mentioned before. This is problematic, it's costly, it's invasive. We have to do an endoscopy to get this sample. There's potential for contamination, and remaining sterile during an endoscopy is difficult, and some bacteria aren't able to be cultured. It's also sampling the proximal small bowel and nothing in the distal small bowel. So breath testing is a more practical approach that we're perhaps more familiar with. So breath testing includes administration of a substrate. We typically use glucose or lactulose, and this is metabolized by bacteria in the small intestine. From there, these products, hydrogen and methane, are absorbed into the bloodstream, moved to the lung, diffused, and expired through the patient that took in the substrate. And then we measure the levels of hydrogen and methane at variable intervals after ingestion. So this is a schematic of that. So again, glucose or lactulose as the predominant substrates that we use. Now we have to think about these substrates a little bit differently. So glucose is predominantly and almost completely absorbed by the time you get to the proximal jejunum. So it is a specific test. However, it's not sampling the entire small bowel. We could have distal bacterial overgrowth, and in that case, you could have a false negative test. So it's specific, but it's not as sensitive. Lactulose, on the other hand, is not absorbed in the small intestine, and so you could have a peak in the early small bowel or the distal small bowel, so it is sampling the entire small bowel. However, in some of our patients, we think about them having diarrhea, having potentially increased oral cecal transit, so your lactulose may reach the colon earlier than expected, in some studies even 20 minutes. And so you may have a peak of positive test based on lactulose, but this is actually related to colonic fermentation and not small intestinal fermentation. So it's a sensitive test, but not as specific. You could have a false positive based on colonic fermentation. So interpretation of these tests, and there is variability among studies and how people use this, but generally we want a baseline value. We want to see how much our hydrogen and methane rise above baseline and by how much. The timing of the rise, before 90 minutes, before 120 minutes, and the pattern of the rise. So a rise of 20 or more parts per million from baseline in hydrogen by a 90-minute mark should be considered a positive test for SIBO. 2 peaks on a breath test are not required, however, for diagnosis of SIBO. And a level of greater or more 10 parts per million is considered positive for methane on a breath test. So here are 3 graphs representing different outcomes. The first graph, looking at hydrogen and methane levels versus time, is a negative test. So we can see from baseline, hydrogen, which is our red line, methane, which is our black line, don't change over time from their initial baseline values. Our second test is a positive hydrogen breath test. So from baseline, we see at least a 20 or more increase in parts per million of hydrogen excreted. You can see at the 90-minute mark, we're at 120 parts per million. And then the bottom graph is a positive test for methane. So again, our black line showing that more than 10 parts per million increase. We typically wait about 120 minutes for methane, but we can see this is an early rise and an early positive test for methane. So ACG clinical guideline, again, published in 2020, gives some instructions for what we should tell patients prior to testing. Antibiotics should be avoided at least 4 weeks prior to breath testing. Ideally, we're stopping pro-motility drugs and laxatives for at least a week before testing, although this is difficult for a lot of our patients. They should fast for 8 to 12 hours and avoid complex carbohydrates the day before testing, so essentially a low FODMAP diet the day before testing. Avoid smoking on the day of the test. This can increase hydrogen excretion. Limit physical activity. Hyperventilation can decrease our hydrogen levels expired. And then, even though it's strongly associated with SIBO, it's not necessary to stop your PPI before testing. Even though there are no diagnostic tests for SIBO, you can see some of these lab abnormalities if someone's positive. B12 deficiency, bacteria compete with B12 and could potentially even cause a disruption to the mucosal barrier that affects absorption. We have bacteria that actually deplete the bile salt pool, thus there's less to basically absorb fat-soluble vitamins. You can see deficiencies. High folate levels, this is related to bacterial production. And in very severe cases, you can have protein-losing enteropathy. Treatment, we're very familiar with antibiotics, short courses, rotating courses. In patients who have structural abnormalities, think about attempting to correct the underlying cause, fistulas, if there's stenosis, adhesive disease. You want to replete vitamin deficiencies. And then think about using prokinetics in patients with motility disorders. So those patients who have irreversible factors, who may have systemic sclerosis, you might want to think about starting a medication for them. And then questionable probiotics for treatment. Here are generally our antibiotic regimens that we use, although other than rifaximin, the data on these antibiotics come from small studies and the quality is modest at best, but this is some of the regimens that we use. Rifaximin, however, has been shown in many studies to be clinically effective in eradicating SIBO. This large meta-analysis in 2017 combined all of these studies, found it was efficacious, although there was a lot of variability among the studies that included. And specifically, the treatment success was higher in those non-randomized controlled trials. So it was higher in the less high-quality studies. They found that drug dose was independently associated with an increased eradication rate. So we think about this when we're choosing our dosing for rifaximin. These two studies showed that the higher the daily dose of rifaximin, which was up to 1,200 milligrams, showed a higher eradication rate. There has been a push for this new term, intestinal methanogen overgrowth, rather than saying methane-predominant SIBO. This is due to a few factors. One, the methanogen in the gut is actually not a bacteria, it's an archaea. Patients may present differently when they have intestinal methanogen overgrowth, and you treat it a little bit differently as well. So patients with methanogen overgrowth are actually 5 times more likely to present with constipation when compared to patients with hydrogen-predominant overgrowth. The severity of constipation has been shown to be correlated to methane levels for positive breath testing, and the choice of antibiotics is different, mainly because this methanogen is resistant to many antibiotics. So 2 studies looked at the treatment of methanogen overgrowth, a little bit older, but both looked at rifaximin or neomycin as one of the treatments. This retrospective chart review in 2003 looked at neomycin versus rifaximin or combined therapy, finding that the highest response rate came from neomycin and rifaximin. And then a placebo-controlled trial in another small study, 84 patients, IBS patients with methanogen overgrowth, treated with neomycin found reduced methane levels on repeat testing. I should note that both of these studies used greater or equal to 3 parts per million to be considered a positive test for methane as compared to the 10, and so it included more subjects and also potentially increased response rate. Recurrence of SIBO or intestinal methanogen overgrowth are not uncommon, potentially up to 44% at 9 months. It occurs more often in patients who are older, those who have had an appendectomy, those who have a history of chronic PPI use. How do we treat recurrence? Well, repeated treatments or cyclic treatments, continuous rotating courses. We could do a targeted diagnostic and treatment approach, potentially less practical, but this would include getting an aspirate, figuring out what bacteria is overgrown, and then choosing an antibiotic that treats that specific bacteria. Treating the underlying condition, or again, trialing prokinetics, erythromycin, prucalopride. Although those have side effects, they're not all universally available, and so may not be a manageable option. So we know there is an association between IBS and SIBO. What's controversial is the rate of SIBO in IBS and the cause and effect between SIBO and IBS. So meta-analyses have showed that up to 78% of patients with IBS may suffer from SIBO, which is a large number. One study, Pilaris and his group, found that SIBO was in 60% of patients of IBS, specifically diarrhea-predominant IBS, compared to those without diarrhea. And then we know that in sequenced microbes in duodenal samples, we've seen higher numbers of bacteria in the small bowel of patients with IBS. And as you all know, we use antibiotics in the treatment of IBS. So big trials, the TARGET trial 1, 2, and 3, they were large multi-center randomized placebo-controlled trials that showed that in patients with IBS, 40% treated with rifaximin for 2 weeks had adequate relief of symptoms. And then the TARGET 3 trial looked at relapsers and showed that treating with rifaximin again versus placebo, again, a significant response. Greater with rifaximin for patients with abdominal pain as well. So this actually led to rifaximin being approved by the FDA in 2015 for the treatment of IBS-D, whereas it's still not approved for SIBO. Probiotics. There are small studies, that show that there is an improvement in symptoms in patients with IBS with and without SIBO. Meta-analyses show potentially probiotics appear to reduce hydrogen production in tests. However, there are uncontrolled smaller studies, actually one that gave bifidobacterium as a treatment for SIBO that actually resulted in a positive methane production. So twice the number of subjects actually had a positive test for methanogen intestinal overgrowth after receiving bifidobacterium. And controlled trial that came out recently showed that probiotics could actually cause SIBO and D-lactic acidosis, presenting with symptoms of gas and bloating, and discontinuing those probiotics and giving antibiotics finally resolved their symptoms. So the bottom line is the role of probiotics is unclear, and at this point we really shouldn't be recommending them as treatment for SIBO. The future of testing, well, there's modern microbiome techniques for the assessment of small bowel aspirates. There's pretty exciting research about indirect microbiome testing, mass spectroscopy for exhaled products. We could obtain the test differently, so administration of substrate actually during the endoscopy. There is oral ingested capsule technology that measures intestinal hydrogen and CO2, or even a smart capsule for detecting bacteria. So we're not there yet, but we may come a little bit further in years to come. So our summary today, presentations and risk factors for SIBO vary. The severe presentation of malabsorption and maldigestion is uncommon in patients who don't have structural abnormalities. Diagnostic testing, the duodenal aspirates where we're culturing bacteria, or the more practical breath testing approach. Constipation can be a prominent symptom in patients who have intestinal methanogen overgrowth, so don't neglect that symptom if we've ruled out other causes. SIBO can be present in patients with IBS. Strength of association is unclear, but we know at least in a subset of our IBS-D patients it is related. Antibiotics are a mainstay of treatment, but remember that intestinal methanogen overgrowth treatment can differ from that, and there are limited data currently on the role of probiotics. Thank you.
Thank you, Dr. DeLay. Okay, now we open the panel, open the floor to questions. Dr. Wallach, there's a microphone approaching you. Oh, maybe not. She's coming, she's coming. And perhaps I should correct myself, Dr. Greenwood. Apologies.
This is for Dr. Ahmed. In your case, would you consider just like after a year's worth of mucosal healing, would you consider just decreasing the azathioprine to like maybe 50, or do you just withdraw it completely?
Yeah, it's a good question. I don't think there's great data to suggest that either approach is different from one another in terms of efficacy of relapsing rate. Personally, I would just withdraw the thiopurine altogether. And
then do you worry about developing antibodies after that, or do you think that period is sort of over with?
Generally not. So I do test for, I do proactive TDM afterwards after a patient is withdrawn from a thiopurine to see if there's any risk for antibody formation. The data suggests that the rate of antibody formation is generally very low in the relapsers even, and there's about a 90% success rate of recapturing response on a retrial of infliximab. So for the most part, I think if you do proactive therapeutic drug monitoring, it's reasonable. Do you have to? Probably not, as long as the patient truly has achieved mucosal healing.
Okay, thanks.
Yeah.
Just a follow-up to that, Dr. Ahmed, what's your specific monitoring protocol once you do de-escalate therapy or withdraw therapy? How frequently do you do biomarker testing? Which biomarkers do you follow? How frequently do you do endoscopic evaluations or other imaging tests?
Yeah, another good question. So in terms of monitoring, so I think there should be some form of a clinical assessment at least at 6 weeks afterwards, after withdrawal of whatever therapy, again at 3 months, and then probably every 3 months after that. From an endoscopic evaluation, I think it's okay to wait up until 6 months afterwards, or if you need to get cross-sectional imaging because the patient has small bowel Crohn's, that's fine. In terms of the exact biomarker, it depends on the patient's history, right? So, maybe 15% of patients never even mount a CRP, so you have to pay attention to that. For the most part, we're checking fecal calprotectins.
And I guess to round out a few additional questions that I had as you were speaking, you mentioned that rescue therapy can be quite successful for the patients who do have relapse of their disease. Do you usually go back to the exact same regimen, or do you reload, or what's kind of your approach, or do you change agents altogether?
Yeah, another great question. I think it depends on the timeline of withdrawal. If obviously a patient, stops infliximab and then they start flaring within 6 weeks, it's probably reasonable just to resume whatever regimen they were on. If there was a prolonged lapse in therapy, so we're talking 6 months, I would reload them. I do screen for antibody formation upon reloading the patients, as this has actually been shown that potentially you will not mount an antibody if you've been off of therapy for quite some time. So typically when you're reloading the patient, you give them 1 dose of infliximab, you check a drug level 1 to 2 weeks afterwards to see if they mount an antibody response. If they do not, it's okay to just continue the reloading.
So ideally go back to the same agent.
Yeah, I think so. It's a good question, though. We just don't really have data to guide us. If someone, was an infliximab or TNF responsive patient, you withdrew them, they started failing. Does that mean they're not a candidate for more newer therapies? Certainly not. But it's hard to kind of just ignore restarting what we know works.
Thank you. Other questions from the floor?
About Dr. Chung, about H. pylori, first, quickly. I started actually screening my patients who were pregnant with hyperemesis for H. pylori, and if you could comment on that. But the second thing is I had a recent patient who came in, first time I'd seen this, saying that their doctor had recommended they get partner testing for H. pylori, and so he turned out to be positive. On the list of reasons why people fail H. pylori treatment, is reinoculation a possibility there?
So I didn't see a lot of data on that, including the hyperemesis part with pregnant women. One thing to think about is more in the setting of recurrent infection. So basically people who were treated with H. pylori had confirmed eradication, then developed it again. One thing to think about is testing family members and seeing if they have it, and then having everyone be eradicated.
I guess to follow up on H. pylori, these are complex multi-drug regimens, and oftentimes we diagnose these individuals and convey the diagnosis possibly in the haze of waking up from sedation, but oftentimes after the pathology has returned. What's your approach to optimizing adherence to that regimen?
Yeah, so there's different techniques about that now. So for instance, I didn't mention, but some of the, for instance, the new regimens, they have like blister packs, so they incorporate it. One thing I do try to think about sometimes is if I can pick regimens where even though there's multiple drugs, taking them at the same time. So for instance, say every 8 hours or 4 times a day, so that way they know all of them are gonna be at the same time. There are certain apps where, for instance, they look at timing. For instance, I believe it was Korea, there's a app that essentially sets an alarm that tells people when to take the drug over the course of 2 weeks.
So maybe it was that same bowel prep app that Dr. Jones showed us earlier today. Great. Other questions from the audience? As we're waiting for folks for their burning questions, Dr. DeLay, you talked about how the distribution of SIBO, or at least diagnostic yield, depending on where we look in the intestine, can be variable. So for instance, we might miss distal SIBO if we're just looking in the proximal small bowel. Is that location related to the underlying anatomic abnormality or disease, or is that just kind of a sampling issue?
Yeah, so there's not a lot of great data specifically in patients who have fibrostenotic disease or adhesive disease, and trying to localize bacteria and associating that with infection or with overgrowth essentially, and their anatomic abnormalities. That's mainly a sampling error. So we can really only get, when we sample ourselves, proximal bowel. So when we're trying to compare breath testing to aspirates to try and get a level of inter-rater agreement, we're still not able to get accurate diagnostic agreement because of the sampling.
Yeah. Dr. Revely, you do a very good job of making people feel at ease. How do you talked about embarrassment and kind of feeling minimized in patients even bringing constipation to the attention of doctors. What's your approach to putting your patients at ease and being able to openly talk about this?
Well, I think my introduction, thank you. My introduction is always that I'm here to listen, and I've learned how to be a listener. I want them to tell me their story. You know, many patients come to us and they've already read a ton of information or misinformation on the internet. It's given them enough confidence that now they feel comfortable coming and seeking care, consultation about it. But I talk to them and I hear the diagnosis that they're making on from their internet, and to try to diffuse that first and say, no, I want to hear your story. What's it like when you wake up first thing in the morning? What's it like at the end of every week? What's it like when you're premenstrual versus in the middle of your mid-cycle if it's a female? And then really I just ask them, you know, I'd really like to hear how much this is impacting your life and your relationships and your family, to get the big picture about not just the symptom. We're all good at that. We can focus on the symptom. I do the same symptom review that I showed you on slides. But it's really about sitting back and trying to be an empathic listener, and then I'm going to take them seriously, and then we're going to have a long shared discussion about how best we can approach this.
It's a good moment to maybe ask the audience. So one of the key points that Dr. Reveille raised during his talk is, what is the principal feature that distinguishes IBS-C from chronic idiopathic constipation or functional constipation? What's kind of the main thing that's different between the two? And you talk about, Dr. Reveille, sort of the importance of listening to the symptoms. How does understanding whether pain is part of the profile kind of change your approach in how you treat these individuals? You said the medicines oftentimes are similar. What's your kind of diagnostic, or not so much diagnostic, but treatment management approach, and how does that differ?
Well, thanks for the, I'm going to tell you that I'm of a camp that believes that IBS-C and chronic functional constipation, since we're taking out the outlet subtype, are really one and the same. And the only main difference is those people who have visceral hypersensitivity, a hallmark of functional diseases, and those who don't. So their patients with CIC actually often do have pain, but it's not a pain that's distracting. They have a low-grade discomfort in the abdomen when they haven't had a bowel movement for 5 days, versus the IBS patient where the pain is a really focusing factor. So we really want to focus on trying to get the bowel habits in order so that the pain that they're focusing on, can be a background feature or goes away.
Thank you. So the next question, we have a question from Dr. Brown. Christy's all the way in the other opposite corner of the room, but she's going to make her way to you, Dr. Brown. It's good to see you. Yeah.
My question is for Dr. DeLay. When I've treated patients, for presumed bacterial overgrowth, I get into an immediate bind. Did they get a response that was real, or was a placebo response? Should I retest them for bacterial overgrowth? And if they have responded, and it may be a good response, how often can I retreat them? I have one patient, for example, who insisted he be treated once a month for his bacterial overgrowth because he really got better. And it was difficult to argue with him about his presumed response. So what's your advice on how to deal with patients who seem to have responded, or they got one treatment? When do you go from there to the next step?
Yeah. Okay. So thanks for the question, Dr. Brown. I don't think I've ever given a talk where Dr. Brown hasn't asked me a question, which I love. So yeah, that happens in a lot of our patients, actually, that if they do respond to the first course of antibiotics, it's not unreasonable to give them another course of antibiotics. So that's to answer the first part of your question. Kind of a sideline to that is if they partially respond or don't respond to treatment, then it's definitely not reasonable to just try another antibiotic. At that point, you may want to actually test them or test them again with breath testing to see if they actually have SIBO or not. But in terms of the patients who request multiple courses of antibiotics, cost alone may be prohibitive, as rifaximin is very expensive. A lot of insurances won't cover that. You always want to incorporate the full team, our dietitian colleagues that I see here, and our GI psychologist as a way to address symptom control in case this isn't all overgrowth. Incorporate that as well. And then in those patients who truly request multiple courses, I've given up to 4 to 5 courses a year, if approved, and that's just what they take to keep them under control.
Mostly because I like seeing Christy shoot across the room, but maybe if Sarah, you don't mind us picking your brain, what have you seen as successful approaches to your dietary counseling of patients who have SIBO, and particularly the ones who maybe get better with medications and just keep wanting monthly prescriptions? How have you seen you can add to the picture here?
Good question. Thanks for putting me on the spot. Let's see. So sometimes patients will come to us and maybe you guys are working them up and you might suspect SIBO or IBS. So we may be talking about possible treatments like with a low FODMAP diet. That's not a there's not a diet that's specifically recommended or has been found to be specifically to treat for SIBO, but we can potentially use it. It's thought that maybe having your patients continue what they're eating and have high FODMAP foods is recommended during SIBO treatment. Again, that's not like definitive. And then afterwards, kind of seeing a couple weeks afterwards, if symptoms persist or have kind of somewhat there, maybe then we can try the low FODMAP diet. That's been my approach. Does that one answer your question?
Absolutely, and I think
Okay.
it brings up this important overlay, the chicken and the egg of IBS and SIBO, and I think the nutritional kind of support, especially for the patients that have an IBS overlap, can be really, really helpful. So as folks are thinking about other questions, we'll pose another question to the audience, and this time it's on the topic of H. pylori. So it's a long question, but I'll summarize it for you. So you have a patient who has a history of peptic ulcer disease, was previously tested for H. pylori and positive based on gastric biopsies during EGD. He has a history of a penicillin allergy from when he was a kid. He was treated with bismuth quadruple therapy, which included metronidazole, tetracycline, and omeprazole, and had a positive fecal antigen test at 4 weeks after completing therapy and adequately holding his PPI for the retesting. So at this time, what therapy would you prescribe this patient? So choice A, refer the patient to an allergist, and if the patient's not truly allergic to penicillin, try a clarithromycin-based triple therapy. Option B is refer to an allergist. If not allergic, actually try high-dose dual therapy with amoxicillin esomeprazole, that regimen that Dr. Chen described. Or refer to allergy, and if not allergic to penicillin, a rifabutin-based triple therapy, or finally, a levofloxacin-based quadruple therapy with metronidazole. It's like pharmacology salad here. So as these responses are coming in, Dr. Chen, what do you think? Why did you ask this question? Clearly, this is a scenario that we run into commonly. What's the best approach from your perspective?
Yeah, so honestly, the answer, like a lot of things in medicine, is it depends, or there's multiple answers. Basically, honestly, there needs to be more information about this to narrow it down, but at this point, there's multiple options for this patient. I would actually lean away from the first patient in part because clarithromycin, we know, is having higher resistance rates, and most areas are going to be, unfortunately, have a higher rate than truly should use clarithromycin. In terms of the other options, it's going to depend more upon, honestly, the patient in terms of how reliable they are in terms of taking, say, multiple medications, or also, obviously, this is assuming they're not allergic to amoxicillin, but then also the cost. At this point, the rifabutin-based therapy is still pretty expensive. And then also levofloxacin, it's going to depend more on their exposures and whether or not resistance patterns, if you have it. But technically, of all of these options, D would probably be the first one to think about, in part because it's still a reliable regimen, assuming levofloxacin has a lower resistance pattern, and then obviously if they're not, if they have no issues with amoxicillin.
Thank you. Clearly, we still have much to learn. We frequently do upper endoscopies. We check for H. pylori with gastric biopsies. From your experience or from data that you're familiar with, what's the yield of biopsies for H. pylori when the mucosal exam is normal?
Interesting, because there are guidelines. For instance, the I think it was ACG guideline does mention still biopsying for dyspepsia even with normal mucosa. So it's something I do still include, although honestly my rate is probably very low, and this is anecdotally, but I think also just data driven. So it is interesting to think about, and maybe it depends on if they need the scope for another reason versus, say, just checking like a fecal antigen test.
Okay. And so for those patients referred for upper endoscopy for dyspepsia or iron deficiency, even if the mucosal exam looks normal, you do biopsy.
Mm-hmm.
And what's your biopsy kind of approach in terms of location, how many bites?
Yep, so I still do like the Sydney protocol. So basically 2 in the antrum, 1 in the sura, and then 2 in the body.
Okay. And then you did mention during your talk that the urease testing sensitivity can change with GI bleeding. Is that also the case for the histopathology, or
It seemed like it was more specific for the urease. However, just to be safe, it does seem like it's more reliable to just do the fecal antigen testing, depending on your pathologist and what they use in terms of diagnosing H. pylori.
Also reasonable in the setting of a GI bleed. Yeah, great. Other questions from the audience? Yes.
Having done tons of high-throughput breath tests over the years, the double peak that you talked about there is the normal finding on this. But I have had many a test that are literally flatline, to the point where I have actually recalibrated the machine halfway through the test because it has not moved 1 part per million in that 90 minutes. What is that indicative of, and what would you recommend for somebody who has that result?
Just give them the rifaximin. No, I'm just kidding. That's very odd, actually, because we know at least there's bacteria in some proportion in the gut. And so a complete flat line would make me think there's some sort of equipment or systems error there, as you thought, recalibrating the machine. Probably worth looking into the substrate as well. But you bring up a good point in terms of what the baseline is. The data are really poor on trying to figure out what increase from baseline when the baseline isn't 0 is a positive test. And so it could be something like that where it doesn't change at all because your hydrogen starts out very, very high and not at 0, which is where they want it to start. So an odd finding. If I had something like that, I may go about another way of diagnosing or truly empirically treat.
You talked about all the potentially emerging diagnostic strategies to diagnose SIBO. What's your advice for practices that don't necessarily have access to hydrogen breath testing or requires a referral, and a patient to see a specialist? Do you do empiric treatment for presumed SIBO, or how do you think about that issue?
I do. I think individually about the patient. So what is their symptom profile? What has been ruled out so far? Maybe what do their diagnostic tests or labs look like? And so if there's a high pretest probability, say they have Crohn's disease or they've had GI surgery in the past, then they probably do have some bacterial overgrowth, and I will empirically treat. There actually is, for some providers that they don't have access to breath testing or aspirates, there is a mail order breath test that you can do and you can look into. I'm not sure about cost, but in folks in a remote location where they really need the breath test, that's a potential option.
Great. Thank you. So I think that'll round out our session, really high yield, broad topic coverage in this luminal section. Appreciate everyone's attention after lunch. We will open to a happy hour. Make sure you take your drink tickets and enjoy a beverage, a snack, and we'll reconvene here at 2 o'clock. Please say hello to the sponsors and make sure you turn in your passport if you'd like to be eligible for the drawing. There's a wedding gift card box at the entrance there you can pop your passport into. It's just a shoebox that we'll draw from. Thank you very much. We'll see everyone back here at 2.